بسم الله الرحمن الرحيم، على بركة الله ورسوله. نفتتح الويبنر لموضوع Antibiotics in Children، ونبدأ بالبروفيسور دكتور يحيى العيساوي. He is a consultant neonatologist. He is the head of an ICU of Saudi Germany Hospital. He has got PhD processing in pediatric pioneer in department in Canada, and has got a clinical research neonatal perinatal fellowship with and neonatal transport in University of Melbourne. He has got Arab board and trained in Al-Mustansiriya University, and he is an international speaker and scientific member. He has a dozen of published articles and papers associated. And would you please, Dr. Yahya, start your talk about antimicrobials in pediatrics?
Thank you, Dr. Professor, my teacher, Dr. Najla, for the introduction. Thank you for ASINO and for the Pediatric Society for giving me the opportunity to talk with all of you about, very important and vital topic, which is antimicrobial in pediatric. And the today talk is, I will give you some, the objectives of this talk is to give you an introduction, the mechanism of actions of antibiotics, the beta-lactam antibiotics. We'll talk also about carbapenem, monobactam, aminoglycoside, macrolides, others. And at the end, we'll give you a summary about what to prescribe for what disease. So, as you know, the antibiotics are mainly of two types: the bactericidal and bacteriostatic. Bactericidal is the chemicals that kills the bacteria, and bacteriostatic the chemicals that interfere with growth. Bactericidal result in dead bacteria, while the bacteriostatic result either interference with the immune system or arrest the growth of the bacteria, and at the end result we will have the same aim, which is killing the bacteria. The mechanism of action of antibiotics varies. Some of them only interfere with the cell wall synthesis, such as the penicillin. Example, we have the the penicillin, the cephalosporin, the carbapenem, the monobactam, the vancomycin. Some of them inhibit the 50S subunit in the ribosome and then interfere with the termination prematurely of the protein synthesis. Example of that, the macrolides, the clindamycin, linezolid, and other interfere with 30S subunits, such as aminoglycoside and tetracycline. Others inhibit nucleic acid synthesis and function. Some interfere and inhibit folate synthesis, such as methoprim, and or inhibit DNA gyrase, such as quinolones and ciprofloxacin. Some reduce the nucleic acid by releasing free radicals, such as metronidazole. The beta-lactams are a group of antibiotics, such as penicillin. Example, we have the long-acting Benzathines Penicillin, the oral penicillin, and the IV penicillin, the ampicillin and amoxicillin, and their augmentin, the clavulinate, and also the ampicillin sulbactam to decrease resistance. We have a group of nafcillin, oxacillin, floxacillin acting mainly about massa, and we have the piperacillin and ticarcillin, which are anti-pseudomonas in addition to the piperacillin and tazobactam. We have the cephalosporin, and they are of 5 generations, and the more down with the generation go, they become more gram-negative. The up the movement, they become more with a gram-positive. And we have the carbapenem, such as meropenem, ertapenem, imipenem, and we have the monobactam, such as the azthrionam. The penicillin, we have the long-acting benzathines penicillin, and it's very long-acting. It's mainly giving IM, not IV, and it's known for its use for rheumatic fever. And usually we give it as one dose, and it's active against gram-positive and anaerobe. An example, group A and group B streptococcus. So GPS and also the Streptococcus pyogenes, also active against syphilis, against meningococcal meningitis, against bacterial meningococcus, and also in dental infection. We have also the ampicillin, and the ampicillin can be given IV and IM or PO, and we have amoxicillin, which is mainly PO, and it's active against extended to, including to, in addition to the gram-positive, it includes the gram-negative, such as Listeria monocytogenes. And this is very important to always combine the ampicillin, whichever the other combined in neonatal life, fearing of the killing Listeria monocytogenes. It's also important in Enterococcus, and it's vital for acute otitis media. It's also very important, both ampicillin or amoxicillin, in community-acquired pneumonia, and also still very active against E. coli, UTI, despite the presence of resistance. First we will be talking about the amoxicillin, the amoxicillin, and to reduce the beta-lactam resistance can be augmented with the clavulinate. And this can be given oral. An example of amoxicillin clavulinate is augmentin, and it's active against extended beta-lactam. Can be used in acute otitis media, in sinusitis, can be used in MESA, methicillin recessive streptococcus, and in animal bite, even human bite, because it's active against Pasteurella and Staph aureus. Other augmentation of penicillin is adding sulbactam, and it can be used IV or IM. Example of that is the Unison. And it become active again more of beta-lactam, and it is very wide spectrum, so we can use it in aspiration pneumonia. Also can be used in lung abscess because it's active against staph. We can use it in animal bite, and you can use it in community-acquired pneumonia because any infection from immunity are prone to resistance due to antibiotics overuse. Other example of penicillin is nafcillin and oxacillin. Nafcillin is IV, but oxacillin can be IV or IM. And they are sensitive or active against MESA, osteomyelitis, meningitis, and endocarditis. And you can see they have a feature that they can go to tissue with poor blood supply. We have the piperacillin, ticarcillin, piperacillin, and tazobactam, such as Zosyn. And the most important till now is anti-Pseudomonas. And actually today I have UTI Pseudomonas. I started, the piperacillin. So still many Pseudomonas resistance are still sensitive to piperacillin. In addition to the gram-positive, the piperacillin, ticarcillin, and piperacillin tazobactam are a good extension toward the gram-negative. They have a good anti-staph, and they work against anaerobe, and therefore they are very important for intra-abdominal abscesses. And again, because of their wide spectrum, we can use it in aspiration. One of the important side effects of penicillin is the penicillin allergy, and they are of two types. They are immunoglobulin E type and immunoglobulin G, and immunoglobulin E is an immediate and mainly present with anaphylaxis, hypotension, bronchospasm. So they mainly affect respiratory, GI, and skin. And we have the immunoglobulin G mediated, which usually late and present with urticaria, fever, arthralgia, and arthritis. But remember that rash can appear with penicillin without allergy. The other group of antibiotics are the cephalosporin. So we have from first to the fifth generation. And you can see if you go toward the first generation, you are more toward gram-positive. When you go to the 5th generation, you are more toward gram-negative. And they have various characteristic and activity. So first generation, they work against gram-positive, including staph, but not the MRSA, only the MESA. And therefore, they are good for skin and soft tissue diseases. They are of two types, of course, the cefazolin IV and cephalexin as oral. The 2nd generation, they work, in addition to the gram-positive, they work on anaerobe. And therefore, they are very important to be used as surgery prophylaxis. Also, pelvic inflammatory disease and community-acquired pneumonia because of their extension toward anaerobe. Example, cefoxitin, it can be given IV, cefotitan, IV and IM, and cefuroxime PO and cefaclor as a PO. We go to 3rd generation, and they have now gram-negative in addition to gram-positive, but again, they don't cover MRSA. But one of the 3rd generation have, such as ceftazidime, although not available very much, have Pseudomonas activity. And because of its gram-negative and gram-positive, are very good as a guessing therapy for meningitis, UTI, pneumonia, and Pseudomonas infection. The 4th generation, in addition to the gram-negative and gram-positive, they have Pseudomonas activity. So they cover gram-positive, gram-negative, and Pseudomonas. An example of the 4th generation is the cefepime. The 5th generation, the importance is Pseudomonas gram-negative, gram-positive, and they have MRSA activity. And an example of that, ceftaroline. And therefore, and kindly keep it your final defense. Do not use it frequently, because you can use it like meropenem as your final defense to, again, a serious infection. So if we lose this one and you lose meropenem, then we can develop what we call a super bug that no antibiotics will work against them. There is something called cephalosporin cross-reactivity with penicillin. The cross-reactivity are very high with the 1st generation between cephalosporin and penicillin, and it's rare when you go down to the last generation. The cross-reaction more with penicillin, rarer with cephalosporin. So if you have reactivity against penicillin, it's less likely to be cephalosporin. It's more likely to be cephalosporin. But if you have cephalosporin, less likely to be with penicillin. So if you give penicillin, you're more likely to get cross-reactivity. If you give cephalosporin, develop reaction, less likely to develop with penicillin. And so they are not vice versa. The carmopinam, the new group of such as meropenem, ertapenem, and imipenem, they are very important. And sometimes they are combined to increase the augmentation with cilastatin, such as pyrimaxine. And they are vitals against the gram-negative, such as Bacteroid fragilis, Enterobacteriaceae, and they are very good against Pseudomonas. They are also working against the gram-positive bacteria, Listeria. So they are a good alternative to ampicillin in neonatal sepsis, and they are important in Enterococcus fecalis. And because of their wide spectrum, they are vitals in the intra-abdominal infections, such as peritonitis, abscess, or when you have severe high-grade unresponsive necrotizing enterocolitis. The monobactam, such as Asteriana, usually the main indication is allergy to penicillin. And because they have the same action with aminoglycoside, so they are not preferred to be combined. And they are very active against gram-negative bacteria, such as Pseudomonas aeruginosa and Enterobacteriaceae. They are not used for gram-positive, and they are not used for anaerobes. Clindamycin, it inhibits the cell wall synthesis by binding to 50S subunit of the ribosome. It's active against anaerobe, against MRSA, against staph, and against strep. So it's very important in soft tissue infection and in aspiration. The problem is two problems, actually. The diarrhea, and the patient can develop Clostridium difficile, and also esophageal ulcer when giving oral. But it's very good antibiotics for aspiration and for soft tissue mixed type of infection, because have very wide spectrum, including staph and strep, and the staph is the MRSA. The aminoglycoside, example, gentamicin, tobramycin, and amikacin, and streptomycin, and they are inhibiting the bacterial protein synthesis by binding to 30S subunit of the ribosome. They are active against anaerobic gram-negative bacteria, such as E. coli or Yersinia pestis and Francisella tularensis. They have some activity against staph. But the good news, when you combine them with the ampicillin, they are synergistic against staph. They are active against mycobacterium, such as streptomycin, and they work against Entamoeba histolytica and Cryptosporidium pavum. And therefore, they are very important in neonatal sepsis. If the patient is inborn, the gentamicin is preferred. If the patient is outborn, the amikacin is preferred. And the reason is the overuse of the gentamicin in the outpatient setting, unfortunately, and lots of resistance. So inborn, start gentamicin, outborn, amikacin. Usually they are combined with ampicillin. The reason, because ampicillin covers listeria, and gentamicin and ampicillin are synergistic against staph. Unfortunately, the aminoglycoside have nephrotoxicity and ototoxicity, and therefore, when we use it for neonatal sepsis, for bacterial endocarditis, for tuberculosis, complicated intra-abdominal infection, complicated urinary tract infection, also nosocomial respiratory tract infection, such as strep or staph. Used for plague. The problem is the ototoxicity and nephrotoxicity. And therefore, after the third dose, we need to measure the peak. And before the third dose, we need to measure the trough. And the trough level usually 0.1 to 2 mic per mil, and toxic is more than 2. And the peak is somewhere between 8 and 10, and toxic is 12. So what you do is either you increase or decrease the dose by 25% if it's low or high. And if the trough is high, you just stretch it out. So you prolong the, and I rarely use a trough, but sometimes I do. And when the trough is high, I stretch it out. But if the trough is low, I just make it closer. I shorten the administration time, the administration interval. The macrolides, example, the azithromycin, clarithromycin, erythromycin, and they inhibit the 50S subunit of ribosome. And they are motilin agonists, so they are used sometime when we have motility, a problem on alias, and they're very active against gram-positive bacteria, and they have very limited gram-negative. And their importance is the H. pylori and pertussis and mycoplasma and chlamydia. So they are used for peptic ulcer, and they use for atypical pneumonia. Their side effect is the GIT irritation, and their side effect also on infant less than 1 month. So you need very careful to be the dose and the duration because of the hypertrophic pyloric stenosis. Sometimes used in prophylaxis. We used to use it, but now is not anymore because most of the ophthalmonitorum is due to chlamydia, and their action against chlamydia are questionable. So we used to give erythromycin or as a eye drop, but it seems it's not effective, and it's better when the patient is symptomatic, you do swab and give a dose of ceftriaxone, because 75% this prophylaxis giving of erythromycin will not be functioning. The rifampicin is very important intracellular because, and therefore it's used for tuberculosis and also for invasive Haemophilus influenzae, and inhibit the DNA depending on deactivation of RNA polymerase. They are used for close contact of meningococcal infection as prophylaxis, and combined with vancomycin for certain staph infections, such as in VB shunt, osteomyelitis, and endocarditis. And also, we can use them for persistent group A streptococcal pharyngitis when we can combine them with the beta-lactam antibiotics. And we can use them for MRSA carriage if we need to cure the carriage, especially if you have in your unit recurrent MRSA infection. The problem is the end, the discoloration of the body fluid and also the hepatotoxicity. So we need to be careful to do a baseline investigation before we start, and also we have to warn the patient about the change in the fluid color. The fluoroquinolones, such as the ciprofloxacin, the ofloxacin, levofloxacin, and gatifloxacin, they inhibit and the only indication when the other drugs are not safe. And when IV antibiotics, other antibiotics are not available. And the properiopactum acne, and also they are important against MRSA. They inhibit the 30S subunit of ribosome and causing killing of bacteria, and they are not indicated below, or they should not be used below 8 years of age unless very life-threatening, such as Rocky Mountain spotted fever, because of their permanent dental staining. The trimethoprim, it inhibits folate synthesis pathway. So that's why it affects the DNA and the protein synthesis. And it's indicated for UTI, methicillin-resistant staph, pneumocystic urovici, and Shigella and Salmonella gastroenteritis, Burkholderia cepacia, and Procilla. The important vancomycin, it inhibits cell wall synthesis, our very good defense against staph. Unfortunately, there is ototoxicity and nephrotoxicity. Vancomycin should be stopped as early as possible because it gets easy resistance. And again, like clindamycin, you can develop red man syndrome. It is very toxic, so you need to monitor the level, but not like the gentamicin. Usually you use the 5th dose because you need more dose to become steady, and need to be giving very slow infusion because of the side effect and effect on the veins, and it's better to be giving through a central line. And when you develop reaction, diphenhydramine is a good option to treat the complication or the side effect. Their level is between 15 to 20 mic per ml. However, this change depends. So in neonate, we go lower level. And when it's less serious infection, such as coagulase negative staph, we even need less level. While in MRSA, such as staph, we need a little bit higher, definitely less. So just before the 5th dose, we do the trough level. And if it's low, again, we stretch out the dose, or we can decrease the dose. We don't do the peak level. Now, how we choose antibiotic, that's very important. Neonatal sepsis, ampicillin, gentamicin, cornerstone. The importance, do not start antibiotics without blood culture. Don't tell me we don't have blood culture. Look for it. Don't do antibiotics without blood culture. It's vital. Inflammatory markers are useless. CRP and ESR are of no use. They just prolong the antibiotics. They are of no benefit. Do not do them. They are not important. They are important only if you have culture negative and you have a clinical symptom And you don't know when the duration, for how long, 5 days, 7 days, 10 days, 15 days. So you do serial. If they are going up, you go longer. If they're going down, you go shorter. That's the only indication. Otherwise, they are not indicated. And again, there is something called ultrasensitive CRP. That does not mean it's a better. It just can measure the lower level. That's all. Now, sometimes you need to change, depend on the unit. And you can change your primary or your first line defense antibiotics and your second line. If you have gonococcal conjunctivitis of a newborn, then the best, ceftriaxone. Erythromycin against prophylaxis or treatment are not very important. So local, you can still use it. But when you have gonococcal conjunctivitis, you need to admit to an ICU. You need to do blood culture. You need to do urine culture. You need to do lumbar puncture. And you need to give IV ceftriaxone. Erythromycin is not enough as a local infection with gonococcal infection. Chlamydia conjunctivitis, erythromycin probably enough as a topical. If you have meningitis, sepsis, and the first 30 days of life, and you don't have line, and it's a first line infection, and you are inborn, then ampicillin and gentamicin. If you are outborn, then amikacin with ampicillin is a better choice. The reason, because of abuse of gentamicin in outpatient setting and multi-drug resistance against gentamicin bacteria, so amikacin is a better choice. If you are more than, you have a line, then vancomycin should replace the ampicillin because of the prevalence of both MRSA and MRSA stuff. If you are meningitis in 30 to 60 days, then ampicillin your choice, but you can add because you have more gram-negative and it's better penetration, so you can choose between ceftriaxone, cefotaxime, depending on your liver status. Meningitis and bacterium, but more than 60 days, now you can add vancomycin because of the staph, and you can add to it ceftriaxone or cefotaxime, depend on the situation. If you have streptococcal pharyngitis, oral penicillin or benzathine penicillin. If you have dental infection, oral penicillin, augmented amoxicillin with augmentin, cefdinir, ceftriaxone. If you have acute mastoiditis, then it's important to add vancomycin with ceftriaxone or cefepime. If you have preseptal cellulitis with a trauma, then you're suspecting staph, then cephalexin if it's MRSA, and clindamycin if it's MRSA. Trimethoprim sulfamethoxam if it's MRSA. Preseptal cellulitis following sinusitis, so you suspect strep or non-typable Haemophilus influenza or Moraxella catarrhalis, then augmentin is your choice or cefdinir. Ceftriaxone also can be used. If you have pneumonia, such as streptococcal pneumonia, then your choice is ampicillin or amoxicillin. If you have pneumonia of school age, which is atypical, such as mycoplasma, then azithromycin or erythromycin is your choice. If you have osteomyelitis, you suspect staph, you go nafcillin. If you are MRSA, you have cefazolin if you are MRSA, but if you are MRSA, you need vancomycin. Linezolid also is active against MRSA. If you are less than 3 years of life, you need to add third generation because of the gram-negative. Osteomyelitis, suspecting Pseudomonas aeruginosa, such as the presence of instrument, then ceftazidime, the fourth generation cephalosporin is your choice. You can add ciprofloxacin, or you can even add your ticarcillin or carpenicillin. Osteomyelitis due to salmonella, your choice, cefotaxime, ceftriaxone is a very good alternative. Osteomyelitis due to Kingi is ceftazidime IV, ciprofloxacin. Syphilis, your choice is penicillin, of course. UTI, there are many choices: trimethoprim, cephalexin, augmentin, cefixime, cefazolin, cefotaxime, ceftriaxone, ciprofloxacin. Tissue cellulitis, if it's MASA, then cephalexin, oral, or IV cefazolin, or nafcillin. If tissue cellulitis is MRSA, then trimethoprim, clindamycin. If there is side effect, you can select vancomycin. Same choices when you have aspiration pneumonia. Post-operative surgical prophylaxis, cephalexin is a good choice, IV cefazolin, and cefoxitin is another choice. Imipenem combined with celestine, such as primaxine, is another choice. Piperacillin, dog bite, because of pastoral multocida, augmentin is a good choice. Ampicillin, sulbactam, another augmented penicillin is another choice. If you have dog bite allergic to penicillin, then your clindamycin combined with methoprim. If you are side effect of clindamycin, yeah, you can choose vancomycin is another good choice. For typhoid fever, the selection of antibiotics depend on your location. So if you are outside Iraq and Pakistan, and it's a complicated and severe infection, then ceftriaxone, cefotaxime, or aztreonam is a good choice. But if you are inside Iraq, because of the resistance, your choice is meropenem. If it's uncomplicated, whether you are from Iraq or Pakistan, so these are list of because of the tradition of using chloramphene, actually better than chloramphenicol. Because chloramphenicol, in addition to this side effect, the usefulness, and also there is high prevalence of multi-drug resistance because of the overuse. So chloramphenicol, ampicillin, and trimethoprim are not a good choice for typhoid fever. So finally, for the antibiotics, please remember that cephalosporin, ampicillin, amoxicillin, and clindamycin can lead to Clostridium difficile, and they present with watery diarrhea, abdominal pain, anorexia, and fever, and they're very serious. So your selection is metronidazole, metronidazole, and something else when you treat these. To decrease the overuse of antibiotics, people start to do something called antibiotic stewardship. This consists of systemic measurement and coordinated effort designed to optimize the use of antimicrobials. And they affect the choice, so you control and monitor the choice of the antibiotics, the dosing of antibiotics, the route of antibiotics, the duration of administration. Now, what I observe from many people working, most of them, they truly select the antibiotics, but they actually don't care about the dosing, and they don't care about the route, and they don't care about the duration of administration. And I've seen that most of people write antibiotics from their brain. They do not review the dose from a reference before writing it. And most of people use ml or a teaspoon or something like that. So this is a big problem, and it results in drug resistance and antibiotics misuse. So the antibiotic stewardship, the goal is optimize clinical outcome, minimize unintended consequences of antimicrobial use, such as toxicity, also the selection of pathogenic organism, such as the Clostridioidosis, formerly Clostridium difficile, they can use to side effect. Also, to prevent the emergence of antimicrobial, the big problem, the resistance. And it improves the susceptibility rate to targeted antimicrobial agent. Optimize resources utilization, and to know that outpatient is the main problem, not in the inpatient. And in USA, in 2011, there is more than 260 million course of antibiotics per year. And the population of USA is 750, about 350 or something, 350. So you can imagine is how much money they are spending. And they are prescribed mainly for respiratory tract infection, skin and skin structure, urinary tract and gastroenteritis. And guess what? 70% are not indicated. The other problem is the dialysis unit and the emergency. And you can see that 30% of antibiotics description in this, or prescription, sorry, in this units are also unnecessary. So how we do the antibiotic stewardship? Commitment, leadership intervention, tracking and reporting, education and expertise, and license suspension. Take the license from people overusing antibiotics. The stewardship program intervention include identifying the high priority conditions that people overuse antibiotics, such as upper airway infection. And the clinician intervention, which include barriers, why the clinicians over-prescribing antibiotics. We have to go for a standard of care and deviation from standard of care. And the doctors have to know some watchful waiting or delaying the prescription. It's actually management. It's not doing anything. It's actually doing something by not interfering. So people and physicians and pediatricians need to know what is something called watchful waiting. And thank you very much. I'm done. If you have any question or you want to go to the next session, but if you have time, I can take questions.
I think Prof. Najla, she's here.
I can read the question, Dr. Khalaf, before you start, or you can go and then we take the question, whatever you like.
Whatever you prefer. I don't think it's a problem. Whatever you prefer.
Okay, Dr. Najla, can
Yes.
you hear us?
Yes, I can hear you.
Okay. Can you please introduce Dr. Khalaf to start?
Yes, now. Professor Khalaf, he is a consultant pediatrician at Haifa Pediatric Training Hospital, and he is a professor in the University of Ishaq. He is the president of Joint of Iraqi Pediatric Association and president of Annual International Pediatric Pediatric Medical Conference. He is president of Annual Elite and Talk Conference in Neonatology and Pediatric. He has past president of International Medical Academy with Switzerland. He is international speaker and scientific committee member of more than 10 international conferences. He is representative of foreign affairs at Iraqi Pediatric Society and Kurdistan Pediatric Society. And will you please, Professor Khalaf, start your talk about antibiotic in pediatric myth and fact.
Thank you, Prof. Najla, for introducing me. Thanks for the colleagues who attend this virtual scientific activity. Thank you, Prof. Yahya, for easing my job today. Thanks also go to Asino Company for supporting this event. Actually, I'm going to talk about, I suppose that everybody is hearing me and seeing my slides. I'm going to talk about antibiotic in pediatric practice, the myths and facts. So what we are going to hear together today is more a practical approach of some of pediatric problems, and we will concentrate about when to use and when not to use antibiotics. First of all, we should always ask a very important question when we are talking about the use of antibiotics. Are they actually necessary? What is the most appropriate? The choice of antibiotic is very, very important. The regime, which dose, what route, although Prof. Yahya had highlighted that the frequency and the duration needed and monitoring the effect is very important. So we should see if this antibiotic is effective or not. The common reason for using antibiotics in children in the office are mostly we use them for non-specific upper respiratory infections, including pharyngotonsillitis, which most of them may be viral actually. Otitis media, also there is now a trend of watchful observation before using antibiotics. Diarrhea, most of the times not needed, and fever without focus of vaccine. Sometime, as if it become a trend, antibiotics actually or antimicrobials are used as an antipyretics, unfortunately, and this is a fact. Why we do these errors? Sometimes we believe in our ability that we are going to treat all infection with fever with antibiotic prescription, but we should know that many fevers are not due to infections, and also majority of the infection in the pediatric clinical practice are of viral rather than bacterial origin. Also, sometimes we believe that we prevent secondary bacterial infection with the use of antibiotics, which is not a fact, and there is no evidence of that unless chemoprophylaxis is indicated and advocated. Then, why we do those errors? Usually, we rush to the latest, the most patent, the broad spectrum, and higher generation, and I always use cefdinir as an example. But many of those may not be the best and also may not be the safest one to be used in pediatrics. Some people depend on injectable as they believe they are better than oral one. The duration, as Prof. has stated, is not actually regulated. And the other point is sometimes many of us, we upgrade and we change the antibiotic when the patient is continuing to have fever. But this fever may not be due to the resistance to the antibiotic or the antibiotic is not working. Actually, it may be that our diagnosis is not correct, or maybe the dose is incorrect, or the route of administration is incorrect. Incorrect choice of drug, the choice of antibiotic is very, very important. And I think Prof. Yahya went very, very well through the choice of antibiotics. Sometimes phlebitis by itself, especially in those with IV lines, it may be the source of fever. And sometimes actually antibiotic itself may be the cause of the fever. So it is not always the fever, persistence of fever after the use of antibiotics is not always due to antibiotic resistance. We should think about those points before rushing and changing the antibiotics. Talking about the resistance, very strangely, the bacteria, they have many enzymes. They have an enzyme in the plasmid which is called the antibiotic resistant gene. Here and it affects the influx and the efflux of the pump of the antibiotics. Also, they have what's called the the antibiotic degrading enzyme, which encodes the degradation, it causes breakdown of the antibiotics. Also in the plasmid, they have what's called the antibiotic alerting gene. And this alerting enzyme is responsible for alerting the bacteria to that. All these together may make the bacteria resistant, because the bacteria are naturally occurring things in the body. And regarding the resistance, I think, and we do believe that it matters more than it does. There are many ways bacteria can get resistance. First of all, there may be some sort of transfer of the resistant gene from adjacent bacteria to another one. The second point, sometimes a bacteria which is infected by a virus may carry this gene, and this gene may be transmitted into the bacteria within the plasmid. Or sometimes one of the resistant genes in one of the dead bacteria also can be transferred into the bacteria, and altogether will work to induce resistance. And those are very, very important basic things to understand when we are talking and to think about when we are talking about antibiotic resistance, actually. So what happens is that when there is excessive and inappropriate, it is a vicious circle. Excessive and inappropriate use of antibiotics leading to resistance, resistance leading to failure of the treatment, and then failure to treatment leading to use of more excessive antibiotics, and so on. And we should break this vicious circle. So the choice of antibiotic should be determined by the focus of infection and the source of infection. The patient's age is very important, and his immunological status. Knowing that it is rather viral and not bacterial is important. Is it community acquired, which is more susceptible to antibiotics, rather than nosocomial ones which are more resistant to antibiotic? In the clinical practice, actually, usually most of the pediatric infections are more community acquired, fortunately, and they are not nosocomial, which are more resistant. I'm going to some case series from real life. This is Sarah. She is 26 months old female, brought with history of fever and some cough with runny nose for 2 days. She had some red eyes. She had a bit diarrhea, but there was no exanthem. She had also cough. And there was also similar case in the family. Look at her throat. You see it is congested with those satellite lesion on the soft palate. How shall we proceed, and how shall we manage this case? Clinically, this is seasonal pharyngotonsillitis, and the management is only supportive. Antibiotics are not needed. The second case, this is Ahmed, 4-year-old, brought with to the clinic with 2 days of history of spiking fever with very mild cough. On history and examination, the eyes were not red. There was no runny nose, no exanthems, but he has a sort of difficulty in swallowing. No history of similar case in the family, and he looks sick even when during the afebrile times. Respiratory rate 28, heart rate 100, tonsils were short. Purulent discharge from the tonsils, as you see, and you see that the palates is not that congested, but the pharynx seems to have some congestion. There were bilateral tender cervical lymph nodes. Ear and nose were normal. Other system examination was normal. How we are going to manage? Clinically, this is bacterial pharyngotonsillitis. Management, surely we need some general and symptomatic therapy. But antibiotics, yes. Choices we are going to see in the upcoming slides. This is what we see in bacterial pharyngotonsillitis. This is the normal one. This is the infected one, and you see the pus drainage and redness. The palates is not involved, but the pharynx is usually congested in those patients. This is just an illustration. So comparing Sarah to Ahmed, you will see the acute onset with red eyes, with rhinorrhea, with cough, with diarrhea, no rash, pharyngeal congestion, but not exudate, There was no lymphadenopathy. The age is less than 3 years, so most probably this is viral. While Ahmed, he has some throat pain, rapid progression. He was sick. The pharynx was congested with some exudate and follicles. Tender cervical lymph nodes, very important. The patient was toxic. His age is above 3, so most probably this is bacterial. So dealing with Sarah, it should be completely different than dealing with Ahmed. The signs predictive of viral infections like presence of watery nasal discharge, pharyngeal erythema, absence of pharyngeal erythema, absence of tonsillar exudates and follicles, no lymphadenopathy, involvement of more than one system like diarrhea and runny nose and others. Sometimes rash will be there, and similar cases in the family. The most important thing is that there is no single definitive sign of infection. But if the age is less than 3, it goes more with viral infection. The virus, it may be rhinovirus, the more common one, enteroinfluenza, parainfluenza, adeno. A special one like cytomegalo, HIV, and now we should always keep in mind also SARS-CoV-2 as a possibility, while bacterial, Streptococcus hemolyticus, and in those who are older than 3 years. Rare one like diphtheria, like Pseudomonas influenzae, Neisseria, maybe some special one like gonococcus microplasma can be causative agent in those patients actually. The choice of antibiotics in those with no penicillin, if the child is less than 3 kg or 30 kg or more than 30 kg, either oral penicillin V for 10 days, BID 250 milligram or 500 BID. Amoxicillin, I'm sure you all know these doses, or single benzathine if the child is less than 30 kg, 0.6 million is if more than it one, and single can be used. In patients who are allergic to penicillin, then we can use erythromycin orally or azithromycin. Virgination cephalosporin can be used, or we can use, those are the first line can be used, or we go to the second line, clindamycin, as Prof. here stated before. The third case, this is 24 months old male brought with history of fever, sore throat, and painful deglutition for 2 days. Thanks to Dr. Sinan Youssef, this picture by him. He has some red eyes, no exanthem, cough was negative. There was no similar case in the family. There were multiple scattered lesions on the soft palate if you see them. So clinically, this is herpangina Coxsackie virus infection. The management is just general asymptomatic therapy, and antibiotics should not be given. This one, 4 years old male brought with history of lethargy, fever, sore throat, normal eyes, no exanthem, cough negative, no similar case in the family. He was febrile with generalized lymphadenopathy and soft hepato and splenomegaly. The tonsils were covered with a membrane over his tonsils. And how we will manage this case clinically? This is infectious mononucleosis, EB virus infection. Treatment is usually supportive. Systemic steroids may be indicated if it's causing obstruction of the upper airways. Antibiotics is also not indicated. Lawin is 14 months old, otherwise healthy boy, had rhinorrhea and cough with temperature of 38.8 degrees for 2 days. On day 3, he became fussy and woke up crying with multiple times at night. What could be wrong? How shall we evaluate this patient? This is the story in many situations. I am sure you have crossed that. You are going to see the ear with this erythema, with this fluid behind the tympanic membrane with impaired mobility. Or you will see this bulging in the tympanic membrane, and here we will think of acute otitis media. 50% are penicillin non-susceptible strep pneumoniae, or 50% they will be beta-lactamase producer, H. influenzae 20%. It may be Moraxella catarrhalis in 10%, and 20% will be others. How we will treat this patient? Paracetamol is as effective as ibuprofen as a painkiller. Antibiotics, now there are two schools. In uncomplicated acute otitis media, watchful observation for 2 days, they found that many of them, they don't need antibiotic. If it is complicated, or if after 48 hours there is no improvement, then you are going to go to the antibiotic for 10 days in divided doses. The first line is either amoxicillin or amoxicillin plus clavulinate. The second line are second generation cephalosporin, like cefaclor or cefuroxime, or if amoxicillin was used as a first line, then second line you can use amoxicillin plus clavulinate. Another important point, decongestants are of no value and has no rule according to the recent guidelines. Lava is a 10-month-old, brought on the 2nd of September 2020 with illness of 2 days, started with 6 to 7 times vomiting per day with some fever, then frequency of stool, had diarrhea like 12 to 15 times per day. It was watery, large in quantity. She was artificially fed and also taking a weaning diet. On examination, she was ill-looking with depressed anterior fontanelle, dry skin and mucous membrane, sunken eyes, rapid low volume pulse. How we are going to pass to this case? This is winter, infant, artificially fed, started with vomiting, mild fever, then watery stool. Mostly this is viral and antibiotic surely not indicated. What you will do, seeing this patient, if there is purpura, oliguria, you should immediately hospitalize. If you have a child with a specific infection, we are going to talk about it, or if it was macroscopic blood in the stool, this is different story. If it was watery diarrhea, like this case, we will assess the dehydration. If it is mild to moderate, we should start with oral rehydration solution, zinc supplementation, continuing frequent feeding, either if the baby is bottle fed or breastfed, don't stop it. Severe dehydration, then this is an indication to give IV fluid, continue RS, zinc supplementation, continue feeding, don't stop feeding, and please no antibiotics. Only when frequent stool with macroscopic blood is seen, we should think of amoebic dysentery. Common pathogen are Shigella, enteroinvasive E. coli, Salmonella, Campylobacter, Yersinia, and others. Shigella is most common in those who are younger than 5. Never mixed etiology, mixing bacterial, bacillary with amoebic dysentery rarely occur. Peak usually in bacterial, it occur in the summer. It is more severe in those with malnourished and also in bottle-fed babies. The choice of antibiotic for acute dysentery is cotrimoxazole. Actually, the resistance is very high, especially in Iraq, followed by first-generation quinolones, nalidixic acid, norfloxacin, ciprofloxacin, and also cefixime, ceftriaxone in the dosage. Usually, the duration of the treatment are for 5 days, not more than that. Then, if you have someone with acute diarrhea, as we said, if the child is has oliguria, tired, then should be hospitalized. If there are systemic infection, you should direct the antibiotic for that systemic infection. If there is macroscopic blood in the stool, then we should rule out risk factor and non-infectious causes for that. Otherwise, we treat with third-generation cephalosporin, oral cephalosporin. Oral rehydration solution is very, very important to treat dehydration, zinc supplementation, and continue feeding. Then follow the patient within 2 days. If the patient is improving, we continue further 3 days, and that's enough. If the patient is not improving, then the second line medication, quinolones or ceftriaxone, and reassess within 2 days. If the patient is improving with less blood in the stool, with decreased abdominal pain, with decreased stooling, then complete for further 5 days. If there is no improvement, then we should check for the trophozoite. If it is present, we should treat with metronidazole, flagyl. If not, If it is absent, then we should think about other causes like inflammatory bowel disease, which can cause also bloody diarrhea and sometimes fever in those patients. So this is an illustration of clinical presentation. And if you see in most of the condition, we actually don't need antibiotics. So we have some golden rules to summarize it. Acute infections always present with fever, but in acute infections, absence of fever does not justify the use of antibiotics. Second, infections, the most common cause of fever in the practice actually, but it is most of them are not bacterial in origin. Mostly the upper airway are caused by viral infections, so antibiotics are not indicated. Viral infections should never be treated with antibiotics. Clinical differentiation is possible between bacterial and viral one, and it is very important to differentiate with them. We have those points when it affects multiple systems, as we said. If the patient usually stabilized by day 3 or 4, they are comfortable, they are not looking ill. Mostly they are viral in origin. While in bacterial condition, it is usually localized to one part, like acute tonsillitis. Usually there is no chest signs, there are no running nose. Fever is moderate, but it peaks after 3 to 4 days, not stabilize after that. CBZ usually in the acute phase does not differentiate, and we should not depend on that. The other point is that chronic infection may not be associated with fever, and the diagnosis
You guys hear us? I can take some question until Khalaf comes back.
I'm sorry, I think for those who are living in Iraq, I suppose that you hear me now.
Yes, we are hearing you.
Yes, we hear you, Doctor. Please proceed.
So the people who are living in Iraq, they will understand that the electricity is off. And this is one of the lessons for myself and for all the colleagues. Always have second choice next to you when you are in a troublesome condition, and when the electricity is off, then you can have a second choice and you can do continue your presentation. Although I am not sharing the slides now, I was just talking about the golden rules. I'm going to wait until it comes back. In chronic condition, it is wise to wait for some time after observing that. Waiting for 1 or 2 days before starting antibiotics is really wise. Choosing single oral antibiotics covering the suspected gram-negative or the gram-positive is also important. Combination of 2 antibiotics is just justified. It's only in serious bacterial condition. Also, we can, in the first visit, we can wait for like 48 hours before starting the antibiotics. It's not going to harm those patients. Unless you have serious conditions, then it is wise to start with that. I'm waiting the electricity. I have a table. Let me see if my net is connected again. In a minute, I will be back to you. It is just connecting. Once it is connected, I'm going to leave from here, and I'm going to continue on the other side, the other net. So now I hope I will be able to connect again with the. I do apologize for the inconvenience, and I'm going to join from my laptop now and going to continue because I was going to stress on one of the points with which Prof.
Shall we move to?
Apologize. I am back. I suppose that you hear me now.
Yes, we are hearing you.
Thank you very much. I'm just going to share this last two slides, the choice of antibiotics, actually. The choice of antibiotics, I think it is sharing. I suppose that the slide is clear now and everybody is seeing it. So in pharyngotonsillitis, the first line is penicillin or Virginase cephalosporin. The second line, amoxicillin macrolide. Otitis media, sinusitis, amoxicillin. Second line, amoxicillin plus clavulanic acid or second generation cephalosporin macrolide. Pneumonia, the communicable acquired one, high dose amoxicillin or amoxicillin plus clavulanic acid. Cloxacillin is one of the choice. The second line, second and third generation injectable cephalosporin or vancomycin. Dysentery, if bacterial one we are talking, first generation quinolones or third line, third generation oral cephalosporin, and the second line are the second generation quinolones and the injectable cephalosporins. Urinary tract infection, Prof. stated that trimethoprim sulfamethoxazole, amoxiclav, amoxicillin plus clavulanic acid, oral third generation cephalosporin, or the second line we can use aminoglycoside and quinolones. So the take-home message, lastly and not leastly, first of all, irrational and overuse of antibiotic is a great concern, and we should always think about it. We should start antibiotics only if it is indicated. Always use the first line drugs. Don't rush to the second line. Use the microbiology lab more often because sometimes we depend on our skills for that. Develop a culture of culture.
I want to give.
Yes.
Can I give a short
Yes.
comment about this?
Yes, please.
Okay. So there are many questions about the antibiotics and antiviral use of COVID-19. The answer is simply none. Zero. No antibiotics, no antiviral for COVID-19. The treatment is supportive. Nothing is recommended. Antiviral is case by case. You discuss the case, you see that, and then you decide. But 99%, the management is supportive. If you want to save a baby, you need to support the respiratory system. You need to support the cardiovascular. You need to support the cardiovascular. You need to support the coagulating system. You need to support. Supportive, supportive, supportive. There is no magic antiviral for COVID-19. The other question is co-infection. I disagree. Do not give antibiotics for co-infection. The reason why, because COVID-19 is an ischemic infection, and viral and bacterial is hyperemic infection. So there is no way COVID-19 causes secondary infection. And to differentiate that, you can use lung ultrasound. Put the lung, put the Doppler. If it's ischemic, then this is COVID-19. If it's hyperemic, then this is hepatization bacterial. There is no link between them. Even if you find bacteria in the upper airway, it has nothing to do with COVID-19. So please, there is no magic anti-COVID-19. COVID-19 management is supportive. You need to have good NICU. You need to have good PICU. That's how you, and please don't give pure oxygen to COVID-19 patients. You cannot connect COVID-19 patient to the oxygen cylinder. You're actually killing them because we human being deal with 21% because our body cannot deal with oxygen radicals. You cannot give more than 21% for a longer period of time. If the patient need more than 4%, then escalate the support from non-invasive to invasive, from conventional to high frequency. From high frequency, you add something else: sedation, painkiller, muscle paralysis. So support, support, and support. And I've seen even in the TV, the people putting masks directly for oxygen. This is simply incorrect. You need to use a blended, humidified, heated oxygen. You cannot use pure oxygen. And there is no antibiotics for COVID-19. There is no antiviral for COVID-19. You're wasting your time. You are adding more chemical to the patient, actually. So very simple. If you suspect secondary bacterial infection, it is not related to COVID-19, because COVID-19 infection is ischemic. And there is no way it can produce bacterial infection. It killed the bacteria, actually, because bacteria need blood. And just put an ultrasound, you'll see the difference. Very easy to differentiate. So that's very important comment. COVID-19 management in sick patient, antiviral, case by case. But I would say 95% antiviral is not indicated. Comax that the doctor was talking is not indicated for COVID-19. So just need very clear. So now you can ask me any question, but because this is just being repeated about COVID-19, I don't know if Khalaf have any comment.
I absolutely agree with you. Actually, we're on the aim, you know, actually, we are in Iraq and we all know the practice in Iraq. Unfortunately, even the paramedics, they are using antibiotics, but at least being professionals, we should try to avoid the use of antibiotics actually as much as we can. And as I stated, even in acute otitis media, if it is uncomplicated, now in Germany, they have what's called a watchful way. They wait for 48 hours, and those with watchful and those with the receiving antibiotics, they were similar in outcome. In a complicated one, then you are obliged. And even if you don't have serious bacterial infections, one should not rush to the use of antibiotics actually, because really the use of antibiotics is an ecological threat to our globe. By after 50 years, we will have bacteria which is resistant to all available antibiotics.
I think
That
we
is
have
the super quick. Okay, go ahead. I'm happy to answer the question. There are a lot of questions typed. I can type them, but I also can answer them.
They were, most of them, they are asking for the presentation we are going to share with them.
Okay.
But most of the question we already answered, yes.
Yes, sir. What about fosfomycin and new uses in children and upper respiratory tract infection? Dr.
Oh, that's very good question. That is very good question. Well, first, in neonate, don't use it because it contains sodium, especially the Canadian brand. It has a sodium and can cause hypernatremia. Okay, and in children, they have lots of side effects. So please be careful when use this medication. And in neonate, don't use it. And if you use it, please watch the sodium level. And especially if you have hypotension and you're using vasopressin, just be careful to combine the phosphomycin. So there are lots of side effects of this medication, and most of the data are very limited. There is another question about what type of antibiotics in dialysis. There is no any special antibiotics, just use the dose function. There are other questions about macrolide and hypertrophic pyloric stenosis. Go ahead.
Yes.
What's the question? Dr. Najla, what is the question?
Now about
Dr.
cephalosporin
Najat, I think get disconnected. So there is a question about the macrolide and hypertrophic pyloric stenosis in infant. Is it only one of them? Or all of them? Go ahead.
There is a question about safety profile for the use of ciprofloxacin in children. Dr. Yahya?
I am back.
Good.
Yeah, so there is a question about the hypertrophic pyloric stenosis and macrolide. Is it one of them or all of them? Now, the hypertrophic pyloric is observed by Smith, and you have to know that this was like a post-marketing side effect. So after the release, they observed that they can cause hypertrophic pyloric stenosis, and it's associated with all of them, not only one. The other question is when the Clostridium difficile present after the antibiotics, it can be within or after 21 days. So that can happen. What about teeth staining with tetracycline? When it can happen? It's idiosyncratic. So it can happen after 1 dose, can happen after 10 doses, no difference. What about the antibiotics crossing the blood-brain barrier? Most of cephalosporin and penicillin does not, but when there is inflammation, the permeability change and they invade, so they can cross. About the placenta, the antibiotics are divided 3 types of crossing the placenta. There is someone called complete penetration. So what they did, they measured the level at the cord and at the mother. So when they find it the same, they call it complete. When they found it in the mother higher, they call it incomplete. There are only one medication that called exceed. So you have complete, incomplete, and exceed. So there are one medication actually in the mother, in the baby is higher than the mother. I think it's called Cephalosporin or something like that. So antibiotics and the placenta, they're stable. I can provide. Complete, incomplete, and exceed. So you need to select. So which point? I don't know if anybody has a question I can answer.
About azithromycin and COVID.
No indication, sir. No indication. No use. Absolutely not. COVID-19 management in children is supportive. You need to have a good PICU, good NICU to support these babies. Anything else, you can use it, but don't depend on it. Actually, it can worsen the situation because they are chemical. So you need to support the respiratory system. Do not use pure oxygen. Use good sedation, well hydration, support the heart, support the coagulation system, support the blood pressure, and good sedation, good analgesia, good cardiorespiratory support, monitoring system. No chemical absolute, whether it's written in American Academy or in a Canadian Pediatric Society or WHO, I can assure you, they are useless. Don't depend. You can use them, but don't pneumonia and the bacterial infection. Do you do chest X-ray? Do you do lung ultrasound? Do you do aspiration and you do like a swab? Do you see the inflammatory cells? Do you do culture? Is it blood culture? Because the diagnosis is difficult. So I would not use the answer co-infection. There might be a co-infection, but COVID-19 does not cause the infection because COVID-19 is an ischemic process and bacterial infection. So they might be together at the same time as a coincidental. In that situation, you have to treat regardless whether you have COVID-19 or not. But if you have a bacterial infection and ultrasound, lung point of care ultrasound, I can assure you, it's a very good tool to differentiate between both. The a bacterial infection as hyperemic infection because COVID-19, if you look at the lung ultrasound finding, they are 12. They're totally different from because they are lobar and interlobar. They have less pleural effusion, and they have subpleural consolidation, while bacterial infection, they are hepatization. And of course, there are two types of bacterial infection. So you can easily differentiate. So if you have bacterial infection, regardless you have COVID-19, you have to treat. Okay, you whether Amoxicillin or something else depend on the criteria. I'm not against it, but I'm against the link between bacterial infection and COVID-19.
The use of
Thank you,
antibiotics
Doctor, for
by
highlighting
the
this point.
mother before coming to doctor. What do you
I don't know how to answer this question. she has to go to a child family service and take the child from her. So that would be my answer. So call the child family service and take the child for a foster care and check the level of the level of care of the mother.
Explain the correlation between chemotherapy and immune compromise. What do you mean?
Chemotherapy and immunocompromise. I don't know what is the question.
What is the question? I don't know.
Chemotherapy and I don't understand the question.
I think this is something about how chemotherapeutic agents suppress the immunity by causing leukopenia and other side effects. I don't think.
There are many ways to cause immunotherapy,
yes.
and I don't know what is the question. So, is there any other question I did not answer?
Chronic use of antibiotic in chronic tonsillitis.
There is nothing called chronic. There is a term of chronic tonsillitis. There is no chronic tonsillitis.
No, there is no. I agree. There is recurrent tonsillitis.
Recurrent, okay, but no chronic tonsillitis. Nothing called chronic tonsillitis, actually.
No, there is no chronic tonsillitis.
Yes.
Duration of Mironam in IV in neonate and infant. Duration of treatment.
The meropenem in the duration?
Yes.
Which one? The sepsis, meningitis?
Yes.
With line, without line? What is the gestation? Then I can tell you. Because I can use it to 21 days. For example, if we have the Iraqi bacter, the Acinetobacter baumannii, you need about 6 weeks. If you have, it depends on the bacteria, but if you have just a staph associated with line, and you remove the line and the culture is negative after removing the line, then it's only 10 days. So it really depends on the situation. There's no and depend on the situation, the type of the bacteria, the gestation of the baby, the postnatal age, is it primary or secondary? Is there a central line or no? Is hemodynamically stable or consider with the duration?
Line treatment and early onset sepsis and babies less than 34 weeks.
In early onset, meropenem is not indicated. Meropenem should not be used.
No. Ampicillin and amikacin,
if it's outborn because of the common use of gentamicin outside, so there will be like a drug resistance. So if you are outborn in community-acquired nosocomial, amikacin and ampicillin. If you are inborn, never went out, you are hot from the labor room to an ICU, then gentamicin is the ampicillin are the best. And I hate the word upgrade. There is nothing called upgrade. Okay, if your antibiotics and deuterate, do blood culture. Okay, and switch the antibiotics. That's all. And also, you need to depend on your bacterioboma, your hospital blood culture tells you what's your bacteria, and then you can decide what's your first line. But I can assure you that 90% of units around the world, the first line is ampicillin gentamicin.
Yes. Effect of fluoroquinolone on cartilage and bone. Does limit its use?
Yes. So if you don't have other alternative, your bacteria is resistant to all the antibiotics, and you don't have anything sensitive, and or you have allergy to IV antibiotics, and you are below 12, then you are allowed to use. Otherwise, it's better to be used after 12 years because of the effect on the cartilage.
The explanation for reaction to penicillin type 1, type 2, type 3 hypersensitivity.
It's either immunoglobulin E mediated or it's immunoglobulin G mediated. And penicillin is a protein, and it's considered as a foreign for the body, and the body start to fight, and the fight are different, either immunoglobulin E immediate or immunoglobulin G late, and sometimes can cross-react with cephalosporin.
Can you use ciprofloxacin in infants?
Yes, you can. But again, if you have multi-drug resistance, if you have no other options, and if you don't have IV, then yes. Otherwise, you have more common antibiotics, less side effect.
Is augmentin recommended as an empirical or once the bacterial infection happens under 5?
Empirical, or you can use it as empirical. You can use it as empirical because it's a broad spectrum, and it's against beta-lactam. So like otitis media or UTI, soft tissue infection, you can use it as community-acquired pneumonia.
Yeah.
You can use it. It's not good for aspiration pneumonia. It's not good for staph. It's not good for MRSA, but it's a good for as a guessing therapy. And also, if you do blood culture and you have sensitivity, sometimes some of the bacteria, even E. coli, you can find it sensitive to. Sometimes resistant, but you can find it sensitive. So you can use it as a guess therapy.
Can you use topical antibiotic in the neonate at site of puncture or post removal of adhesive state?
Wow, you have infection at the injection site?
On the site of the venipuncture or removing of adhesive state?
Yeah, you can use them. You can use local.
Topical antibiotics.
Topical antibiotics you can use, but I doubt any benefit of that. If you have an infection at your site, then you need to make sure your sterility when you insert in and carrying your line. The nurses has to check the line every 8 hours. You never keep the line dry. You always keep hip lock. And if you see any side effect or the pressure in your pump is increasing more than 300 millimeter mercury of your blocked, then you need to monitor. But if you get an infection frequent at your site, you have a big problem in the NICU. So you need to change their practice. I never seen local infection in the line, never in my life. And if I see it, there is a reason. But if I see it, I would change the practice. I will follow why. Hand washing, carrying the line, keeping hip lock, changing the line, cleaning. Probably the injection is a problem. You have a contamination. So I think you need to solve the problem other than applying local. If you're adhesive, use certain adhesive that cannot cause a skin trip, and avoid the adhesive. If you have you don't have adhesive, use gauze to fix the things. Use Tegaderm, which is like a nylon type of. If you have a local problem, you need to solve it. You need to solve it because this is a big problem.
What about antibiotic used at first line in case of increased CRP? should antibiotic modified, changed, or what?
Which age? First, why you do a CRP? What's the point? Because if you have a car accident, your CRP will be high. If you are upset, you're not happy, you didn't see a movie, you didn't sleep. If you didn't see a movie in the cinema, your CRP will be high. If you have ventilation, your CRP is high. So why you do CRP? That only two indication of CRP. Okay, first, your culture is negative. You are already on antibiotics and you are still symptomatic and you don't know the duration. So we do CRP serial 2 or 3 times. If it's then you go to a longer duration. If it's decreasing, you go to shorter duration. That's one indication. And second, you have a high risk factors. You are asymptomatic. And you're not sure this is contamination or not. So you do CRP, and if it's negative, then this is more with contamination. That's the only 2 indication. Otherwise, CRP inflammatory is the only indication, the only benefit is prolonged antibiotics use. More resistance, more side effects. So CRPs are of no use.
Yes.
I don't do them. I never did them in 12 months. I never mean never.
What antibiotic would you use in immune compromised patient?
Which antibiotic?
Yes, which antibiotic you will use in immune compromised patient for treating infection?
Chemotherapy. There are different indications.
Yeah. Is low dose erythromycin advised for gut motility in neonates?
Which type? Sorry, I missed the question.
Low dose erythromycin advised for gut motility in the neonates. No. Checking level of gentamicin we do before administrating second dose or 2 dose administering two dose.
This is a very good question. So if you think that you will stop the antibiotics before the 3rd dose, then no need to do. If you think you will continue, you can do it before and after the 3rd dose, and you can do it before and after the 5th dose. So the trough before the 3rd dose and the peak after the 3rd dose.
What are the factors that make you think of using empirical therapy? The factor which we consider if we start empirical therapy for patients.
So can you repeat the question because your voice interrupted?
What are the factors which we consider if we start empirical therapy for patients?
Factors depend on the age, the gender, the risk factors, the gestation, the invasive procedures, availability, your antibioma, clinical situation, what bacteria we suspecting, what is their location, is it vascular or extravascular, is it mixed or not mixed, is it resistance or not? There are many factors where you consider, how to start the empiric treatment.
Choice of cephalosporin antibiotic for bacterial gastroenteritis in child.
None, 0.
No rule. No rule.
No rule. 0 rule.
What is the mean disulfiram-like effect caused by cephalosporin?
Can you repeat the question?
What is mean disulfiram-like effect? DISULFIRAM.
Those patients, they those who develop flushing and nausea like alcohol reaction, throbbing headache in side effects of cephalosporin. And just like flushing, vomiting, nausea, throbbing headache occur. It is just like patients with sometimes they like reaction to alcohol adverse effect of cephalosporin.
Yeah, definitely. Also, they present with abdominal discomfort, chest pain, headache. Exactly, if you are drunk, you will become flushing, dizziness, as Dr. Khalaf was indicating.
Use of antibiotic in neonate in case their mothers has a leak of catapevia.
Prolonged rupture of membrane, none, zero. Even if the baby born in a sewage, inside sewage, and if the baby asymptomatic, no antibiotics. However, remember, prematurity means symptomatic. So if a premature and prolonged, yes, antibiotics. If a premature and active labor, antibiotics. It's always correct to start antibiotics, but it's always wrong to continue antibiotics after 48 hours if the blood culture is negative. Now, some people say the blood culture report comes after 5 days. When we say 40 hours, either no report or the report is negative. So if you don't have report at 48 hours and your child is asymptomatic, stop antibiotics. So if there is a leak for 10 days and the baby is a term, then no antibiotics. But if there is a leak and the baby is a preterm, then antibiotics. If the baby preterm and the mother in labor, then antibiotics. A guessing antibiotics. 48 hours, culture negative, start negative. If no report or negative.
Somebody wants you to have a lecture on asthma in children and this is treatment. Also use of antibiotics in that case.
Asthma, there is no antibiotics, zero antibiotics. Why you give antibiotics in asthma? No antibiotics, very simple. Now, asthma can be prone to secondary infection, and that's pneumonia. It's a different presentation. So I have, like, in last month, maybe 10 patients, and I have 120 visit to my clinic. I use only 2 antibiotics. One for UTI, Pseudomonas, another one is Pseudomonas aeruginosa, and the other one, girl, is Enterococcus faecalis. That's the only antibiotics I use in the whole month. And I have lots of asthma patients. Asthma is steroid. Steroid, and then anything else. Steroid. If you have asthma and reaching the hospital, steroid. And please don't use nebulizer. Use inhaler. Use spacer and inhaler. Because then spacer, nebulizer, the waste is like 90%. While in inhaler, the waste is only 5%. So use inhaler. Use your Ventolin and ipratropium bromide. Use your inhaler steroid and use systemic steroid. Don't delay the systemic steroid. And there is no need for antibiotics. I never use antibiotics in asthma. I don't know why people think antibiotics is an emergency medication or antibiotics is a life-saving measure. And when a baby deteriorate, antibiotics and the baby, when baby deteriorate, they need support. They need ventilation. They need breathing machine. They need hemodynamic support. They need coagulation. They need care. They need sedation. They need pain killing. They need support. They need intensive care. They need PICU and ICU. They don't need.
What about tigecycline justified use in the neonates? tigecycline used and justified in the neonate. Right.
Can you repeat the question, Dr. I didn't hear it.
Sir, what about tigecycline justified use in neonate? يمكن يقصد tetracycline خاص.
IVIG? I mean, does he mean IVIG?
TIG. Tigecycline.
I don't know what's IVIG. I have no idea. If you can explain
what about
TIG.
What about cloxacillin not sure if you mentioned dose and does the cross.
Prof. Yahya, they were talking about tigacycline used in some resistant cases who are resistant to resistant Klebsiella. They can use tigacycline in neonatal sepsis.
يعني هو من جماعة التتراسايكلين من جماعة التتراسايكلين هو
Tigacycline. No, it is tigacycline.
tigacycline.
Yes.
Is it the same like a tricoplanin or it's a different one?
Yes.
I don't know.
Yes,
I have no
yes.
experience with it. I don't know. If you tricoplanin, it's the same like vancomycin. But I have no experience. I never use it.
If in case of meningitis and have resistance to vancomycin and mironimine, what do you use?
Staph, so MRSA and resistance to meropenem and vancomycin.
Yeah.
Oh, you are in a big trouble. So I guess you need a synergism of 3 medications. So what you can do, you can use clindamycin, you can use methobrem, you can use ceftazidime, you can use 4th generation cephalosporin because they have anti-staph. It really depends on the situation and the sensitivity. So if you have the resistance, then you should have the sensitivity.
In case you use vancomycin and gentamicin below 30 days, what the precaution and follow-up to prevent nephrotoxicity and doses IV line is mandatory rather than IV cannula?
Okay, so if I have an infection and I have a central line, I go for vancomycin and gentamicin. So what is the precaution? Use weight-adjusted and gestation-adjusted doses.
Good.
Second, check the level of gentamicin, trough and peak on the 3rd dose, and vancomycin on the 5th dose. If the peak is high, drop the dose by 25% and then repeat after 5 doses. If the trough is high, then stretch the dose out. So if you are giving it every 12 hours, give it every 18 hours. If you are giving it every 18, depend on the gestation, give it every 24 hours. Same for gentamicin. After 2 days, maybe 3 to the fade, you will have the sensitivity of the, if there is a bacteria, of course. So and then you can decide with 1 antibiotics, you don't need to continue. The other thing, if it's persistent, so you do your culture, after 48 hours, you have to repeat the culture. If it's still persistent after 48 hours, you need to remove your central line, put peripheral, wait 48 hours, check the culture again. If it's still positive, then repeat after 48 hours. If it becomes negative, then insert a central line again if you need the central line. So you need to follow the patient, and it's not difficult to manage the situation.
I think there is a time in and out of entry and exit. How many days and months and year will it last? Are there any certificate, diploma, and baccalaureate to be issued? About what يعني?
Dr. Mahmoud, if you can, talk, say your question. I don't understand the question.
Dr. Muhammad.
Dr. Muhammad, what is the question? I did not understand the question.
Another one, please, if you have seen my post, explain to me if you understand anything about the link. What mean that group discussion, please? Group discussion.
I don't understand the question.
That's the last 2 questions. Probably.
Yeah. So if somebody have any question, they can speak up if they want the answer.
Yeah.
Like anybody has a question, they can go live and ask the question.
And thank you very much, Dr. Yahya and Dr. Khalaf and Dr. Noor, and thank you, as you know, for this very wonderful webinar. It is very interesting. I hope.
Thank you very much. And please,
Thank
please limit the antibiotics use. Please, antibiotics is not an emergency medication. Please remember that.
So we have reached to the